following podcast is part of a certified educational activity titled Targeting TIGIT to Extend Immunotherapy Benefits to More Cancer Patients, a Strategy to Amplify Immune Response and Enhance or Restore Anti-Tumor Activity. Access the entire activity and complete the post-test at peerview.com/EBJ860. Downloadable slides, practice aids, and additional resources are also available.
Hi, it's a pleasure to be here to discuss a new strategy with immunotherapy in cancer, targeting TIGIT to extend immunotherapy benefits to more cancer patients. My name is Dr. Zev Weinberg. I'm a GI oncologist and co-director of the GI Oncology program and director of the Early Phase Clinical Research Program at UCLA, and I'll be moderating this program. I'm joined by my colleague, Dr. Shirish Gadgil.
Hi, Dr. Weinberg. Yes, I'm Dr. Shirish Gadgil. I'm the Division Chief of Division of Hematology Oncology at Henry Ford Cancer Institute and Henry Ford Health System in Detroit, Michigan.
And we're happy to be presenting this data and some of our discussion points about this novel target. So we recognize that immunotherapy has changed the landscape of how to treat cancer patients. Most of that has been impacted by the addition of anti-PD-1, PD-L1, and CTLA-4 inhibitors, recognizing that combination strategies are often the best way to treat patients, regardless of the cancer. But we also recognize that we still have a lot of improvement that needs to be made. There's a large proportion of patients who simply don't get enough benefit from existing immunotherapeutic strategies, and a lot of patients don't respond at all. So efforts are ongoing and have been ongoing for many years to investigate novel immunotherapy targets and novel immunotherapy strategies to see if we can both expand the group of patients who get benefit from these agents, and equally important, to improve the outcomes of those patients beyond the existing treatment strategies that we know already work. So TIGIT, which stands for T-cell immunoreceptor with Ig and ITIM domains, is a novel checkpoint that we'll be discussing today. Some of the way we'll be discussing it is with respect to mechanism of action, targeting it with antibodies and other drugs that are in development. And the premise is that this will ultimately be a new option for many patients for immunotherapeutic drugs. So the first module, Shirish and I will be discussing TIGIT as a new targetable checkpoint in cancer immunotherapy. And we'll be going through some of the basic principles of TIGIT biology and discussing how combination strategies are being developed to, as mentioned, enhance the group of patients who get benefit. So we've got to keep a few things in mind. First of all, TIGIT is an inhibitory receptor of the PVR-like family. We'll be going through some of the known ligands and a lot of unknown aspects of this checkpoint. And we'll also be discussing the value of checking certain biomarker assays and whether certain patient selection strategies that are already being utilized for PD-L1 and CTLA-4 inhibitors can be extrapolated to the use of anti-TIGIT-like molecules. When we look broadly at the immune system and the interplay of its role in cancer, we recognize that T cells have been the forefront of checkpoints and are themselves the primary cell type that, of course, will be stimulated or inhibited sometimes to play a role in the fight against cancer. And what I mean by that is that we all have some basic understandings of immunology and oncology, and we all recognize that for many, many years it's been known that certain cancers lend themselves to immunotherapeutic strategies. We can see here on this cartoon that there's a complex, continuing, dynamic interplay between both T cells that are both helper T cells and natural killer cells, or CD8 positive T cells, with the tumor cells, in the context of antigen presentation, and also in the context of often a very complicated tumor microenvironment involving stromal cells, tumor-associated macrophages, and other cell types that certainly play a role both in the ability to recognize cancer as foreign, but also sometimes to protect the body from insult. And so tumor-associated macrophages are a good example of cell types that often should not be stimulated necessarily as we get into some of the specifics of cancer immunotherapy. And the complex interplay is something that we've known for many years is not a simple process. At the moment, we have two main checkpoint inhibitors that are approved, or two main checkpoint inhibitors for which drugs are approved. Obviously, the most common is PD-1 or PD-L1 inhibitors. That is probably, we have 4 or 5 checkpoint inhibitors approved for various cancers, both in hematologic malignancies like Hodgkin's lymphoma and also in a number of solid tumor cancers for which the approvals are ongoing and to some extent continue to every year expand their use in oncology indications. CTLA-4 inhibitors, there are obviously several of those also available, the most prominent being ipilimumab, but there are others as well. And these drugs are also approved in certain contexts, often not as extensive as PD-L1 inhibitors for a number of reasons that we'll talk about. But these are two different checkpoints on the T cells that we know now how to target, for which there's a number of drugs approved.
And what I would add is that, as mentioned in this slide, and though this is not absolute, that it appears that CTLA-4 may have a greater role when the T cells are being primed by the antigen-presenting cells in the lymphoid tissue. And that is probably the reason why with anti-CTLA-4 we see a much more systemic immune activity, whereas the PD-1, PD-L1 checkpoint may have a greater relevance in the tumor microenvironment, and so the immune-related AEs may not be as pronounced with the anti-PD-1, PD-L1. Though this is a generalization, there is a role for anti-CTLA-4 even within the tumor microenvironment. And this is a factor, particularly when we combine these agents, both in terms of efficacy but also in terms of toxicity, and that is definitely a reason to look at other checkpoints.
Yeah, great point, Shirish. And I think that, that brings us on TIGIT. So I'll let you briefly give us some background on this new novel checkpoint.
So what I would say is that what is recognized is, though we have been focused on CTLA-4 and the PD-1, PD-L1 pathways, there are several other molecules on the T cells that are both stimulatory as well as inhibitory. And there is an interest in developing drugs that inhibit the inhibitory checkpoints, whereas agonistic antibodies that activate the stimulatory molecules present on the T cells, with the hope that either as single agents or in combination with the currently available checkpoints, we could enhance the immune response against the cancer even greater. It is quite likely that these checkpoints play an important role in patients who do not derive as much benefit from the current checkpoint inhibitors as may be seen with these drugs in development. One such protein rather is TIGIT, and Zev is going to now discuss the biology of this TIGIT pathway and its interaction with its ligands, as well as its the benefits of co-inhibiting TIGIT and PD-1.
Thanks, Shirish. And as you mentioned, we're seeing other ones like LAG-3 inhibitors that will probably soon find their way into development, certainly already have evidence that they may work with PD-1 inhibitors in melanoma, for example, and other more checkpoints along the way. Now for TIGIT, which is somewhat unique in that it isn't present at all, it seems, other than on T cells or natural killer cells, it's a checkpoint discrete from the other checkpoints, and by that I mean there doesn't seem to be necessarily a requirement of PD-1 and CTLA-4 overlapping, although in most of these cases it is. And by that I mean that the ligands that bind are discrete from the known ligands that bind PD-L1 and CTLA-4. The primary ligand of binding is something called PVR, otherwise known as CD155. And this seems to be the primary important ligand that is known to bind to the TIGIT receptor and essentially providing the inhibitory signal that it does. The premise being, if we can block that TIGIT, we can therefore prevent the binding of those ligands and functionally in the same way that we do with the PD-L1 and PD-1 interaction. Now, there are a whole bunch of issues with respect to what we don't understand. And by that I mean, this is, I'd say, at its early phase, TIGIT biology. It's certainly not as well understood as PD-1, PD-L1 interactions, and CTLA-4 for that matter. There seems to be no presence of TIGIT, as far as we're aware, on tumor cells itself, that it's discretely on T cells and to some extent on natural killer cells, as mentioned. But that interaction between TIGIT and PVR provides an immunosuppressive environment, which leads to increased activation of dendritic cells, increased activation of other cells that leads to a profound immunosuppressive environment. So if we can limit that environment by somehow blocking it, that's the premise in this case. So one of the interesting factors is how these checkpoint inhibitors interplay with each other. I think we're going to see a lot more about this topic in the next few years, but we recognize already that there's convergence between TIGIT and PD-1. And a recent manuscript published, led by scientists at Genentech, tried to get some hypothesis-generating ideas about what the convergence is. It seems to be that TIGIT only competes with CD226 for ligand binding. Remember that the primary ligand for TIGIT is CD155 or PVR, and here the competition is with another ligand, CD226. There's also direct interplay between co-stimulatory and co-inhibitory molecules that are blocking different elements of checkpoint inhibitors on these cells. And by that I mean there have been several mechanisms that have been hypothesized to understand how they both may work to regulate CD226. Shirish, I wonder if you can comment on some of that interplay as well.
Yeah, so what this paper to me highlighted was the relevance of the co-stimulatory molecules. We were aware of the relevance of CD28 in the activity of anti-PD-1 agents, in that if an anti-PD-1 agent is given for the T cells to be activated, you not only need that inhibition of PD-1, but then the co-stimulatory molecules such as CD28 and CD226 need to be activated for the T cells to then have an effector function against the cancers. It appears from this paper that CD226 is required for a response to anti-PD-1 or anti-PD-L1 agents. The paper suggests that the combination of an anti-PD-1 with an anti-TIGIT appears to activate CD226, a co-stimulatory molecule on T cells, far better than either agent alone, and that may be the basis for doing dual inhibition.
When we speak about the drugs, and again, as mentioned in the beginning, tiragolumab is probably the monoclonal antibody the furthest along in development, in clinical development for an anti-TIGIT strategy. It's, as Shirish mentioned, it is a Genentech molecule, and it is a fully human IgG1 kappa anti-TIGIT monoclonal antibody with an intact FC region. And we'll talk about that a little later, what the meaning of that is. And it blocks binding of TIGIT to the receptor or to the ligand, PVR. And anti-TIGIT antibodies, such as tiragolumab, the premise is, have an enhanced role to play, particularly in combination, as Shirish mentioned, with PD-1 antibodies. These have been granted breakthrough designation by the FDA based on some lung cancer data that Shirish will now go into. I'll point out there are many other anti-TIGIT monoclonal antibodies in clinical development, and we'll be touching on some of those at the end of this presentation. As a summary to this section, let's now take a look at a 3D animation depicting TIGIT as a novel rational immunotherapy target in oncology. We all know that the immune system can protect against cancer. However, tumor cells have evolved various ways to escape immune cell recognition and/or killing. One powerful mechanism that tumors use to evade immune surveillance is an activation of immune checkpoint pathways. For example, PD-1 is an immunoinhibitory checkpoint receptor expressed on T cells and natural killer cells that interact with its ligand, PD-L1, which is frequently expressed on tumor cells to evade the immune system, promoting tumor cell survival. Use of immune checkpoint inhibitors in the form of anti-PD-L1 or anti-PD-1 antibodies can enhance cytotoxic T cell responses to tumors, causing tumor cell death. These immunotherapies are currently widely used in oncology practice, but only a small proportion of patients benefit. Additional novel approaches are needed to extend the benefits of immunotherapies to more patients with cancer. T-cell immunoreceptor with immunoglobulin and immunoreceptor tyrosine-based inhibitory domains, or TIGIT, is a novel negative immune checkpoint expressed on T cells and natural killer cells. TIGIT is a co-inhibitory receptor that binds to its inhibitory ligand, PVR, also known as CD155, expressed on antigen-presenting cells and tumor cells in various solid and hematologic malignancies. TIGIT works in conjunction with PD-1 and dampens the immune response by outcompeting its co-stimulatory counterpart, CD226, for binding with PVR. Both PD-1 and TIGIT disrupt activation of the co-stimulatory receptor CD226 on T cells and NK cells, providing strong rationale for dual immune checkpoint inhibition. Preventing PVR-TIGIT signaling using anti-TIGIT antibodies may restore anti-tumor immune response and amplify the anti-PD-1 or anti-PD-L1 antibody effect. Dual immune checkpoint inhibition with anti-PD-1 and anti-PD-L1 and anti-TIGIT antibodies has been shown to synergistically enhance T-cell mediated effects, leading to tumor cell death and near complete elimination of tumors in preclinical models. There has also been compelling, promising clinical data with respect to endpoints of progression-free and overall survival in patients in randomized clinical trials. Many clinical trials are ongoing with these combinations and will be presented in the years to come.
So the next module is going to discuss targeting TIGIT in solid tumors. I'm going to discuss initially the randomized phase 2 CITYSCAPE data in metastatic non-small cell lung cancer. This has led to several trials in metastatic non-small cell lung cancer as well as small cell lung cancer, also in stage 3 disease. And then Zev is going to discuss the data in metastatic esophageal cancer, but there are several tumor types where these combinations are being evaluated. And because the data set that led to a breakthrough designation for this combination was in lung cancer, we're going to start with the lung cancer data. And this breakthrough designation was based on the results of the CITYSCAPE trial. This data has been previously presented, but there was an update in December in the ESMO Immuno-Oncology conference. So the design of the study was patients that were treatment naive and had stage 4 non-small cell lung cancer. The patient's tumors were tested for EGFR and ALK, and they were wild type for EGFR and ALK. And the patient's tumors had to have PD-L1 expression of 1% or greater by the 22C3 DACO IHC assay. A total of 135 patients were enrolled, and they were randomized to tiragolumab plus atezolizumab at their standard doses of 600 milligrams IV Q3 weeks and atezolizumab at 1200 milligrams IV Q3 weeks. And patients were randomized to atezolizumab plus placebo. The treatment was continued until progressive disease or loss of clinical benefit. So there was an opportunity to continue treatment beyond RECIST-defined progression if it was felt that the patient was deriving clinical benefit. The co-primary endpoints were overall response rate and progression-free survival, with key secondary endpoints, of course, of toxicity, duration of response, and overall survival. There were exploratory endpoints of efficacy analysis by PD-L1 status, and there was data on patient reported outcomes. These are the baseline characteristics of the over 130 patients enrolled on the study, and they were very well balanced with regards to stage, sex, ethnicity, smoking status, and the PD-L1 status. So since only PD-L1 positive, patients with only PD-L1 positive non-small cell lung cancers were enrolled, about 50% of the patients were PD-L1 1 to 49%, and a little less than 50% were patients with tumors that were TPS score of greater than or equal to 50%. So this was the primary endpoint in the intent to treat a population of progression-free survival. There was advantage seen with a hazard ratio of 0.62. This translated into an improvement of about 15% in the progression-free survival rate at 12 months with the combination of tiragolumab plus atezolizumab. The median PFS was approximately 5.6 months with the combination and 3.9 months with single agent atezolizumab. However, when you looked at analysis based on the PD-L1 status, it appeared that the benefit was primarily seen in patients whose tumor PD-L1 expression was high or equal to or greater than 50%, with a hazard ratio of 0.29 and an impressive progression-free survival of 16.6 months with the combination, whereas it was 4.1 months in patients who received placebo plus atezolizumab. It appears, at least based on this exploratory subset analysis of this trial, that there did not appear to be a benefit with the combination in patients whose tumors were 1 to 49% with a median progression-free survival of 4 months with the combination and 3.6 months in patients who received atezolizumab plus placebo with a hazard ratio of 1.007. This indicates that though in the overall population there was a benefit with the combination, it is quite likely that the combination is most likely to be effective in patients with a high tumor PD-L1 expression. There was also a trend towards improvement in overall survival with a hazard ratio of 0.69 with the combination. That translated into a median overall survival of 23.2 months with the combination as compared to 14.5 months in patients who received placebo plus atezolizumab. Clearly, with immunotherapy, what is impressive is that sustained benefit that is observed in a proportion of patients. And that is sort of evident here in the survival curves when you look at the 24-month survival rate, which was 34.3% in patients who received atezolizumab plus placebo. And so a 13% increase with a 24-month rate of 47% with the combination. So almost 50% survival at 2 years with the combination. And again, the benefit appears to be limited to patients whose tumor PD-L1 expression was high with a hazard ratio of 0.23 and a very impressive improvement in 24-month survival rate of 78% with the combination as compared to 33% in patients who received atezolizumab, whereas there did not appear to be a difference in survival between the patients who received the combination versus the patients who received atezolizumab plus placebo. So the survival data was consistent with what was observed as regards to progression-free survival. Now, nivolumab is also combined with PD-1 inhibitors. Rather, nivolumab is also combined with ipilimumab, that is, combination immunotherapy has been evaluated in lung cancer. And the primary reservation about using such combination immunotherapy in advanced non-small cell lung cancer is that there is increased toxicity with combination immunotherapy. And so in general, the toxicity was somewhat higher with this combination, but very manageable. So any cause adverse events were very similar in the two arms. So were the grade 3 and 4 treatment-related AEs in the combination. If you looked at all treatment-related AEs, there was a slight increase. Important to note that there was no difference in terms of the percentage of patients who discontinued treatment because of AEs. It was 14.9% in the patients who received the combination and 13.2% in patients who received atezolizumab plus placebo. This is well reflected in this sort of bar graphs. There does appear to be infusion-related reactions seen with the combination, but doesn't appear to be much different than what was, it is a somewhat higher rather, I apologize, compared to patients who received atezolizumab or placebo. Increased risk of skin rash and pruritus. And this is one toxicity that appears to be definitely seen more commonly with the combination than seen with the atezolizumab, but generally quite manageable. And rest of the immune-related toxicities were not as commonly seen with the combination as observed with atezolizumab alone. I would point out that hypothyroidism, which is another commonly observed immune-related adverse event seen with atezolizumab, is not any greater or not significantly greater with the combination, at least in this trial. And so as when you look at AST, ALT elevation, that is hepatitis with the combination. So generally well tolerated, though there are clearly some immune-related AEs such as infusion reactions and skin rashes and arthralgias that are probably more common with the combination than what was seen in patients who received atezolizumab plus placebo. The study also looked at patient-reported outcomes as assessed by the EORTC QLQ C30 scale. And what was shown was that despite using combination immunotherapy, there was no difference as far as patient-reported outcomes are concerned. That is, there was no greater toxicity translating into increased symptoms for the patient based on these analyses, suggesting that the benefit that was observed with the combination was not at a cost of increased symptomatology among patients who received this combination. And when you looked at the lung cancer related symptoms, there was an indication that there was some improvement or greater improvement with the combination than as compared to patients who received atezolizumab alone. So when you looked at the global symptoms, there was no increased symptoms observed in the patients who received combination. But when you look at lung cancer related symptoms, there appears to be somewhat of a trend to improved benefit with the combination. So in conclusion, tiragolumab plus atezolizumab provided clinical meaningful improvement in this CITYSCAPE trial in terms of progression-free survival, overall response, overall survival in the intent to treat population as compared to patients who received atezolizumab plus placebo. With the 30 months median follow-up, the median overall survival was not reached in the PD-L1 high patients. Tiragolumab and atezolizumab was quite well tolerated. Patients generally maintained their baseline global health status in both arms, and lung cancer related symptom burden remained minimal to moderate over time in the patients treated with tiragolumab plus atezolizumab. And based on these results, the FDA has granted a breakthrough designation for this combination. Of course, further follow-up of this trial as well as the randomized trials that now have completed, randomized phase 3 trials rather, that have already completed enrollment will truly define the benefits of this combination. But this data suggests that this combination has a high promise, particularly for patients whose tumor PD-L1 is high. Next, Zev will discuss the data in esophageal cancer with this combination.
Thanks, Shirish. And you know, the important thing, and this is one of the elements that you know, as we rush to get novel therapies to patients, we do keep in mind that each one of these studies has already gone through a phase 1 study. For example, tiragolumab was dose escalated to get to the point of 600 milligrams, and combinations with atezolizumab, which of course is the PD-L1 inhibitor that Genentech of Genentech's is the combination that we're starting with here. It doesn't mean it'll be the only combination, but certainly prior to that, we recognized, and I summarized it here on the left, that a combination of a phase 1A and phase 1B was done in many different cancers to look at the optimal situation. And here, as Shirish alluded to, the first indication of increased efficacy was indeed in that CITYSCAPE trial with non-small cell lung cancer, particularly the PD-L1 high patients. Now, amongst the GI cancers, there's recognition that esophageal cancer, and to some extent gastric cancer as well, also lend themselves to checkpoint inhibitory strategies. And by that I mean we now have several indications for pembrolizumab and nivolumab in gastroesophageal cancers, both in the adjuvant setting and in the metastatic setting. So there's recognition that within the GI oncology milieu, the esophageal and gastric cancer patients are the group of patients who seem to have some benefit, which can be also in selected patients, to PD-1 inhibition. And so this trial, which I was able to present last year at ESMO GI, looked at an expansion cohort of patients with esophageal cancer, regardless of their histology, which included both squamous cell and adenocarcinoma, and looked at the combination of tiragolumab and atezolizumab. This was a small study, of course, because at that time it was being done in multiple cancers at once, and we were interested in particularly focused in on esophageal cancer because, as mentioned, we knew that PD-L1 inhibition has a role, but doesn't do as well as in lung cancer. So we're trying to expand the group of patients that get benefits. So here are the 21 patients who were on an expansion cohort. They were a mixture, as you can see, of squamous cell and adenocarcinoma. It was a global trial, so in the Far East or Southeast Asia in particular, there's a much greater tendency to have squamous cell, whereas in the Western world, in the United States and Europe, we're a little more commonly seeing adenocarcinomas of the esophagus. Now in this study, which really combined the two, as Shirish mentioned, the combination was tolerable. There was an increased immune-mediated adverse event profile as recognized from single-agent checkpoint inhibitors. I certainly agree with Shirish that the predominant combination toxicity with this combination seems to be dermatologic in nature. There's definitely an increase of rash in these patients, and I've seen it myself in a number of these patients. But overall, this is a well-tolerated combination. It doesn't include chemotherapy. So there's an interest in obviously trying to develop a non-chemotherapy strategy for patients with esophageal cancer as well, just like our friends in lung cancer have done successfully. But as you can see, we have to be in mind as we combine immunotherapy drugs, we're going to get increased immune-mediated side effects. They're not always reflected as grade 3 to 4 adverse events, as Shirish mentioned, but certainly grade 1 to 2 events are increased when we combine both CTLA-4 and PD-1 or TIGIT PD-1 or LAG-3 PD-1. We're going to see them. Now the efficacy of this population was encouraging. Esophageal cancer that's heavily pretreated is not one that usually lends itself to respond to anything, unfortunately. And this is a group of patients who had progressed on standard chemotherapy options, which included both FOLFOX or CAPOX and oftentimes second-line agents such as taxanes as well. And so what we were facing with is a circumstance where we didn't expect a high rate of response because single-agent checkpoint inhibitors don't have a high rate of response in that context. Now, here we reported that of the efficacy evaluable patients, which were only 18 for confirmed responses, we had 5 responses out of 18, which was encouraging, and I don't think it's anything that we're satisfied with, to be candid, but certainly encouraging that there may be something to this combination immunotherapy strategy in a disease like esophageal cancer, particularly because the disease control rate was about 50%, 9 out of the 18 patients. A number of these patients were quite durable. As you can see here on the spider plots, that if the patients responded, which included both squamous and adeno histologies, many of the responses were quite durable. So duration of response among the group of patients who responded was 15 months with the combination of tiragolumab and atezolizumab. Now, our conclusions from that were certainly that this activity warrants further investigation, and accordingly, there are large trials being launched in esophageal cancer to look at this combination. However, the last few years in esophageal cancer have seen changes in the treatment landscape, recognizing that now up front, all patients receive a checkpoint inhibitor with chemotherapy. So unfortunately, unlike non-small cell lung cancer, we are not able to develop checkpoint inhibitor strategies by themselves without chemotherapy so far. It has been essential to reach a larger group of patients with a chemotherapy backbone. And that has now shifted the focus of these combinations of tiragolumab and atezolizumab to be combined with chemotherapy for at least the first 4 months of treatment, 4 to 6 months of treatment with combination chemotherapy. Now, as we mentioned, tiragolumab is the monoclonal antibody targeting TIGIT that is the furthest along in clinical development. And you can see here, we listed many of the ongoing randomized phase 3 trials, which will be read out, some of which will be read out possibly this year in 2022. As Shirish mentioned, there's already a completed study of first-line non-small cell lung cancer in PD-L1 high patients, which has completed enrollment, essentially a phase 3, hopefully confirmatory study of the CITYSCAPE results. There's also ongoing studies in small cell lung cancer, in stage 3 unresectable non-small cell lung cancer, neoadjuvant approaches, and even in patients perhaps with combination chemotherapy. Separate from non-small cell lung cancer, we've got 2 trials ongoing in esophageal cancer, one of which is predominantly in Southeast Asia, looking at a different chemotherapy backbone focused on squamous cell populations. And another is in locally advanced squamous cell carcinoma of the esophagus, looking at the interplay between tiragolumab, atezolizumab, and chemoradiation in those patients who themselves are not resected. So patients who are non-resectable or not deemed to be resectable for esophageal cancer are randomized on that study to standard chemoradiation or chemoradiation with the addition of these 2 antibodies. Beyond that, there's large studies which will be read out in cervical cancer and squamous cell carcinoma of the head and neck. So we expect the next year or 2 to be busy with tiragolumab data in a number of these cancers. Now, it's important to keep in mind that there are a whole host of other anti-TIGIT antibodies in development. And many of these are drugs that are either in phase 1 or in phase 1 expansion studies that are probably in clinical development a few stages behind, I would say, in terms of timelines, but have also demonstrated very promising efficacy signals, particularly in PD-L1 high tumors, just like tiragolumab and atezolizumab. There are a number of these that are already in phase 3 testing, including one by BeiGene, which is ongoing in China for patients with non-small cell lung cancer. And there's a whole host of others which are in phase 2 testing. And we've listed some of them here. The third and final module of our discussion today will include a little bit of a discussion point about the future and about some of the aspects of these combination strategies that are ongoing. And I'd like to start maybe, Shirish, by asking you, do you think in non-small cell lung cancer, for example, we already know that, I think based on the CITYSCAPE data and based on some of the data you presented, that the focus is in PD-L1 high expressing tumors. But do you think there's an opportunity to develop, perhaps with chemotherapy, these combinations in PD-L1 low tumors as well?
Absolutely. I think I would say that the data in CITYSCAPE is very promising in the PD-L1 high tumors. There are patients even today who have a high tumor PD-L1 where we actually do land up treating them with chemotherapy and anti-PD-1 only because the patient has a very high tumor burden, a lot of liver mets, a lot of bone mets, and there's a little bit of a discomfort of just treating the patient with single agent checkpoint inhibitor because yes, the response rates are better when you give chemo in combination with the checkpoint inhibitor. So it's not clear that that necessarily translates into a better outcome. But I think even this Cityscape data raises the possibility that even for those patients, we may be able to provide a non-chemotherapy combination with the combination of, say, tiragolumab and atezolizumab. But as you mentioned, I think the promise is in areas where we are not seeing as much benefit. So when one looks at the chemotherapy checkpoint combination data, the benefit is not as robust in patients whose tumor PD-L1 is either low or zero. Yes, there's a improvement in progression-free survival as well as overall survival. But I think that there's room for improvement, particularly in those subsets. And I think possibly the addition of TIGIT to those patients may provide that benefit where we may see benefits similar to what is observed in the patients with high tumor PD-L1. But what I am very excited about is that possibly the benefits in squamous cell patients and small cell lung cancer patients. When one looks at the totality of data with checkpoint inhibitors, particularly in PD-L1 low and zero, the chemoimmunotherapy combination may not be providing as much benefit as has been observed in the non-squamous patients. And actually, the anti-CTLA-4, anti-PD-1 combination may be beneficial, particularly in squamous cell patients, in patients whose tumor PD-L1 is zero. But as we discussed in the past, that combination is associated with somewhat of a higher toxicity. And so in particular with the low PD-L1 or zero PD-L1 squamous cell patients, I'm extremely interested in finding out what adding TIGIT to a chemo anti-PD-1 combination, what added benefit is provided. And then small cell lung cancer, as is well recognized, though we have approval of atezolizumab and durvalumab in combination with chemotherapy in small cell lung cancer patients, the benefit is relatively modest. There's no improvement in progression-free survival. The median survival is improved by 2 months. So again, a group of patients that may benefit with the addition of anti-TIGIT. But I think as is true with other immune-based therapies, and I think with your phase 1 experience, you can talk to this better than I can. I think it is going to be critical to identify biomarkers that will define the patients that are most likely to benefit with the addition of TIGIT to these to anti-PD-1 therapy, either with or without chemotherapy. And I think that hopefully these trials not only show an improved benefit, but help us recognize who are the patients who are most likely to benefit with the addition of these drugs.
Yeah, I completely agree. I think that, first of all, in lung cancer and esophageal cancer, we have something in common, which we also see this different dynamics between squamous cell and adenocarcinoma, and recognizing its different biology sometimes, and certainly different expression of whether it's PD-L1 or other, immune checkpoint inhibitors. So for example, in squamous cell carcinoma of the esophagus, there was a very large study just done called Checkmate 648 that actually did show that the combination of ipilimumab and nivolumab was better than chemotherapy, but the third arm was even more superior, which was chemotherapy plus nivolumab. So recognizing that that is an example in squamous cell where actually, okay, we do have benefit with a non-chemotherapy backbone, but it's perhaps not optimal. Perhaps just because it doesn't have chemotherapy isn't necessarily the best way to treat these patients. I think as opposed to adenocarcinoma, where we very much feel with adenocarcinoma of the esophagus, for the most part, we're going to need some chemotherapy in there. That going it alone with either double immune blockade or certainly with single immune blockade, outside of MSI high, which is a very rare and an important subset in GI cancers, is probably not going to be superior to most chemotherapy strategies. And I think, the recognition that, the different biological subsets within squamous cell and adenocarcinoma are themselves going to behave differently is going to play a big role in the next few years. We're all hopeful. We always want in GI cancers to be a little bit like our lung cancer colleagues right now, where we can offer patients single agent drugs or single agent or combination immunotherapies without chemotherapy. But by and large, so far, even in gastroesophageal cancer, it's been predominantly chemotherapy backbones. Reflecting the biomarker point, which is very important that you mentioned, Shirish, I think that TIGIT is a very different. We don't have a validated biomarker yet. Many people in gastric cancer aren't even sure if PD-L1 is a validated biomarker for PD-1 antibodies, but we certainly don't have anything even that robust in gastroesophageal cancers, where we're a little ways behind. I will say that in most of my experience with the phase 1s with these TIGIT antibodies, the focus has been on trying to see if, as was demonstrated in your study, is it exclusively this PD-L1 high population, or can we make the existing PD-1 inhibitors work better in a PD-L1 low setting? And that I think is one of the biomarkers that people are focused on, indeed on PD-L1. Beyond that, there is a slew of experimental antibodies. They're not going to be, I don't think, something like TIGIT expression or something like or something immunohistochemical on the tumor. I think it's going to be a very, very different biomarker development strategy that may, whether it's going to be a gene expression profile that lends itself maybe to combination immunotherapy strategies, or biomarkers we've not yet heard of, but it certainly doesn't appear to be on the surface to be ligand expression or immunohistochemical expression of TIGIT that will give us the biomarker that we need for selected in patients. So a lot more work is going to be focused on in these next few years. I want to spend a few minutes talking about toxicity here, because I think we talk a lot about the fact that there's no differences in grade 3 and 4 adverse events between these combinations, but there is a difference in grade 1, 2 events. And I think that we have to be mindful of the toxicities for patients that can be, in some cases, difficult and require management. And I know you have experience with other combination checkpoint inhibitors. In my experience, one of the biggest strategies, as I mentioned earlier, is going to be dermatologic. I think we are seeing increased rates of rash, and keep in mind that reporting rash as a grade 3 event often means an extremely serious rash. So a grade 2 rash can be quite bothersome and troubling to patients, even though it doesn't meet the technical criteria of a grade 3 event. That to me has been one of the single standouts, both with my experience with tiragolumab and atezo, but also even with phase 1 studies that I've done with other TIGIT inhibitors. I wonder if you can comment on some of these other possible expected toxicities that we're going to encounter with double immune blockade.
I agree with you, and I would say that the one other thing I've seen is a little bit higher infusion reactions. I think that there is somewhat more than what I have seen with at least anti-PD-1 or anti-PD-L1 agents. I agree with you about skin rash, and I would like to highlight that there's quite a bit of pruritus, and in a few of my patients, the pruritus has bothered them more than the rash. The rash is discomforting, but can be. Having said that, I will say, and again, I can't claim to have extensive experience, but just overall, the combination appears somewhat better tolerated than my experiences with ipilimumab and anti-PD-1 agents. I would particularly point out that I've not seen the colitis that sometimes can occur with anti-CTLA-4 agents. And I think there's a possibility that the combination may land up, even though it is dual immunotherapy, a combination immunotherapy rather, that the overall tolerability is somewhat better. But absolutely agree we'll need to be very vigilant about managing with, either local sort of steroid applications or sometimes even systemic treatments to take care of this. Dermatologic adverse events is something that will need extra attention from treating physicians.
Yeah, and I think that, to your point about comparing combinations of double immune blockade ends up becoming a tricky thing. I think mechanistically, as we talked about earlier, the impact of blocking CTLA-4 is very different in the immune system, as you mentioned, than compared to blocking TIGIT and PD-1. So in some respects, I agree with you, and that's not a surprise necessarily that the impact of a CTLA-4 combination with PD-1 will have more immune engagement and often lead to more, at least, organ damage as it relates to toxicities such as colitis or endocrinopathies. Interestingly, with the tiragolumab combinations, we are also seeing subtle changes in thyroid function, subtle changes in endocrinopathies that are, I think, to some extent, we're becoming more comfortable with in oncology. But absolutely agree, we need to engage our dermatologists, our endocrinologists. This is going to be important for us to manage these toxicities for the foreseeable future. I wanted to spend a few minutes talking about an individual case that actually I presented in the context of that presentation, and is an interesting reminder of what we feel, what we don't know. And I think that this is a gentleman who enrolled in the study at our institution with metastatic esophageal adenocarcinoma, who actually had a very low PD-L1 expression. And PD-L1, as I mentioned, is a difficult marker in esophageal cancer. It is something that we have struggled with, and the FDA has struggled with as well, because they actually recently gave an open approval to the combination of chemotherapy plus nivolumab, regardless of PD-L1 expression. Recognition that perhaps PD-L1 expression leads to better responses has been our sense in gastroesophageal cancers, but oftentimes that's not the case. And here you have a fellow who has a very low PD-L1 expression using the Ventana SP142 assay for atezolizumab, both on the tumor cells and on the immune cells. I want to point out that unlike in lung cancer, we look primarily at the combination of the immune cells and tumor expression. We look at CPS scores. So it's a different paradigm in some respects for how we measure expression or likelihood of benefit from a checkpoint inhibitor. It's got to do with a combination of immune and a tumor, which is of course discrete from your field, Shirish. But this is a fellow who enrolled after having progressed on durable responses to some chemotherapy regimens. Well, I won't say durable, I'd say short-lived responses, to combination chemotherapy with metastatic esophageal cancer, and really came into the study PD-1 naive. This is a few years ago, so nowadays these patients are harder to find in esophageal cancer, to PD-1 naive. As I mentioned, we have upfront approvals now. But here this fellow came on with liver metastases, had a nice response, and really a quick response, interestingly. And a little bit more than I might have expected with a single agent checkpoint inhibitor. To be frank, if he came into my office today and had a low PD-L1 expression, we wouldn't even offer this patient a PD-L1 inhibitor. So here he gets on this combination immunotherapy study and has a very, very prolonged, durable response of 15 months. Actually was on the study for greater than 2 years, having a PR for the majority of that time before finally progressing. So, I think we really don't know, and some people would say, well, gosh, she might have done just as well with a PD-1 inhibitor. Some of the retrospective studies would suggest otherwise in a case like this, I'll point out. But, there's a lot of things we don't understand, and one of them is why certain patients respond to these agents. It's a good anecdote that reminds us of what we don't know. I wanted to thank you, Shirish, for this great combination discussion. I think we're going to be hearing more about this pathway over the next few years, and thank you for having an engaged discussion on, hopefully, the role of adding some new checkpoint inhibitors to our armamentarium.
Well, I would like to thank you as well. I really enjoyed this discussion, and I do think that we both share a cautious optimism, if I can say, about this target and this drug. And hopefully will benefit more patients with immunotherapy going forward. So thank you.
And thank you to the audience for attending.
This activity is certified by PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at peerreview.com/EBJ860. This activity is supported by an educational grant from Genentech, a member of the Roche Group.